Okay, good morning everybody. How's everybody doing? Okay so far? How many have jet lag? Jet lag? That's great. That's great. Some of us have jet lag. So I'm going to talk about 3D imaging technology, and some of it is going to be building on the things that the doctors Sanders and Silverman have spoken about already. If you really break down the echo machine, we're talking about the transducer, the hardware or the software that is built in, which makes up those 400 pounds that you use to push the machine around, and that's what gives you the processing of the image, and then the display. And probably the most important things in terms of the way that we learn 3D, and that makes 3D a new challenge for us, is the display and the user interface. How do you manipulate what you've acquired? In the past, 3D acquisition consisted of it started out with freehand scanning. So you scanned with your hand with the 2D transducer. Then it went on to mechanical scanning, where a transducer was held on the chest, and then a motor basically moved the transducer from one point to the other, and then it did offline reconstructions. I did some of this early on with Dr. Geva in Houston. And I remember we loaded the stuff into the TomTech computer, and we did that as the last thing in the evening, and then we went home, and came back the next day, and by the next morning it was done processing the data set. So it usually takes a lot of time, very, very difficult. So the goal always was to come to a live kind of idea. And this really was started with a group of folks at Duke, Von Ram, which was the first sort of live 3D transducer. And this was a very big transducer footprint. It looked almost like a grapefruit or a big orange, like maybe an Italian orange or something. And it's what we call sparse array. So there are a few elements in this. The elements are far away from each other, so there's a lot of interpolation, artifact. The machine creates things between the information that's given by the elements. And this is where it builds from the 2D concepts that Dr. Sanders spoke about. When you have this kind of a situation, the frame rates are going to be very slow. So the frame rates were 2 to 5 frames per second, which is very good for these ventricles. For the neonatologist, it's not good for these ventricles because these move very fast. And for these ventricles, to image them, you need frame rates of 30 or higher. Broadcast TV, that I guess Mr. Berlusconi owns, is at 30 frames per second. There have been 3 advances in terms of the image. The first is miniaturization. I'll talk about that a little bit about piezoelectrics, and then a little bit about the display. So all of the computing power in this IBM mainframe, which is from the 1960s, can now be fit on this chip in Steve Jobs' hand. And this is a few years old, so probably this chip is even smaller now. And that's Moore's law, that tells you that the number of transistors that can be fitted on a chip just keeps doubling every 2 years. It's exponential. It's absolutely spectacular the way that this has taken over. And this is what has really led to the evolution of echocardiographic advances. The next thing I wanted to talk about was piezoelectrics. So we start out with a transducer, and Dr. Sanders talked about the crystal and the lens. There's piezoelectric material as well, and that's what fundamentally determines image quality. So let's say that you have a chocolate heart that you're trying to image, and what you have this piezoelectric stuff here. And that is what's responsible for the delivery of ultrasound, and then taking the returning ultrasound and converting it into electric signals, and that's what gives you the image. So when you look at piezoelectric material, so what is that? So that's actually a material where when you apply an electrical impulse and you take that impulse away, the crystals in it align and then they realign. And if they all realign this way, meaning that they all pole in one direction, not a democracy, just all in one direction, then that's great. If they do a little bit of this chaotic kind of thing, then that's not so good. This new stuff is called pure wave crystal. That's a single crystal actually, and that gives you 100% polarization, gives you better signal, less noise, and it's better even not just for 3D but also for 2D and other for general ultrasound piezoelectrics. So the conventional piezoelectric material is actually what's been used since the 1960s when the very first machines were developed, and this is what gives you about 70% polarization. 3D transducers are incredibly complicated. At the end of the transducer head, that rectangle that Dr. Sanders shows you, that rectangle has one crystal in it that has been cut into 3,000 elements. If you can imagine, each of those elements is being controlled. It's electronically insulated from the others. It can be steered independently of the others. I've looked at the electronics of this under a microscope, and the wires are about as thick as a human hair. So when the transducer drops, it's very painful to see. There are circuit boards inside the transducer itself, and that's what gives you the steering. So this is an enormous amount of electronic stuff that happens. I thought I'd give you a couple of examples now of 3D imaging. I'll give you an example of a live image, and then I'll give you an example of a full volume. Just a second here. It's warm here with this thing. Sorry about the delay. This is 3D software, and I think that because very much of what we talk about with 3D is image related, I thought it would be best to just show you the images rather than try to talk about them, and just show you how we go about optimizing them. So we'll start out with this image over here, and basically this is conventional Pattersonal short axis view. Everybody familiar with this 2D view? Anybody not familiar with this view? Okay, so now I'll show you what happens with 3D. Basically, this image started out like this. This is the depth dimension, depth from the transducer. This is the azimuthal plane, orthogonal plane with 2D. Right? There's a third plane, which is this plane over here, this plane, right? So this is the data set. So we have taken a very thin slice and we have given it a little bit of thickness. We made it into a wedge of an orange, all right? When you do that and you look at it straight up like this, it still looks very two-dimensional. You know, then what's the difference between 2D and 3D? And one of the things that you have to do here is you really have to go about optimizing these images. So for example, now we're looking at the mitral valve. Yeah. So this is the anterior mitral leaflet. These are the papillary muscles here, 1 and 2. That's the posterior mitral leaflet there. These are cords. You see cords attaching to the leaflet tips. You see cords attaching halfway up. Those are called strut cords. All right. So you can see this, you know, and then you can kind of turn this thing around and look at it from above. Look at it from the left atrial side. So when you look at it from this side, this is going to match up with pathology specimens that Dr. Sanders will show you later, where this is the anterior leaflet and that's the posterior leaflet. To look at this, we have cut off the left atrial walls and we're looking down. There's a fundamental difference between 2D and 3D imaging. So with 3D, you have to become a virtual surgeon. You have to cut the walls off of something to look inside it. Okay. You're not going to be looking through any kind of walls. It makes no sense. You're like a surgeon or a pathologist. So in this now, the advantage with the live 3D image is that it's a narrow image. You start out with, you know, what happens is the sonographer will see this image on the screen and they'll hit live 3D and the image will become immediately something like this with that transducer. So that's a big advantage because you can immediately get a good quality image. You don't have to process it, think about it, and all of that. You optimize the image the way you optimize a 2D image. A different kind of image is a full volume image, and I'll kind of show you how what the difference is with that. So a lot of people say, I want live, I want full volume, I want instant 3D, you know. So this is what an instant 3D looks like. Because the transducer does not know what you want. The transducer knows that it should go out there, capture a big piece, and bring it back and give it to you. So that's what it's doing. So now the question is, what are you going to do with this? So that's what we're going to learn over the next 3 days. So we'll start out with this, and let me just explain a little bit about this to you. Basically, this consists of 4 wedges of an orange that have been stitched together. You see 4 EKG things there on the bottom? Each of those are required in 1 cardiac cycle, and those have been stitched together. So think about 4 wedges of an orange that are stuck together. So if you're asked to eat that, you're probably going to split it first. So that's what this thing does, it splits it. And when you split it, then it makes it a little bit easier to understand. So now you have an apical 4-chamber view. Alright. And now what we'll do is we'll just make this a little bit crisper. By the way, this is the inferior vena cava coming into the right atrium. So atrial septum, ventricular septum, tricuspid and mitral valves and so on. And you can do a lot of things with this, which you can't do with live 3D imaging. For example, if you want to look at the AV valves and the aortic valve together, to look at how much the aortic valve is wedged between the 2 AV valves, you can cut off the top and the bottom of the heart and look down and then give back the front of the heart, and it looks like this. It looks very unusual. It does not look 2-dimensional. This is not 2D echo, it's 3D echo. So we'll cut off the atria now. This is the patient's right side, left side, posterior and anterior. So this is the right atrium looking down into the tricuspid valve. That's the coronary sinus. This is the right atrial appendage. This is the left atrium, the mitral valve. That's the anterior mitral leaflet. The posterior mitral leaflet is there. This is the septal leaflet of the tricuspid valve. This is the aortic valve that is wedged between the 2 AV valves. Right? But the logic here is that you can do a lot by way of cropping, cutting, cropping, to understand anatomy of the heart and to show different features. So for example, the next thing you could do is you could say, well, you know, I'm just going to cut off, I just want to look at the septum. So you could cut off the sides of the heart and look at the septum like this. So these are very different views. We're not used to seeing these views from 2D imaging. That's the whole idea. So we use full volume imaging for quantitation, for showing complex structures such as common AV valves, VSDs, conotruncal malformations, and so on, and then 3D color flow, which we'll talk about a little bit later. There is this logic of an instant full volume, which is 1 beat instant kind of thing. There's a lot of physics that needs to go into this. This is not ready for pediatric usage yet. The frame rates will need to be very high for pediatrics with this. The transducer frequency will need to be very high as well because we want high resolution. When you talk to the ultrasound companies and you say you want high resolution, high frequency, high frame rate, they say price is very high. So it's not going to work. So with that I'm going to stop. Thank you. Questions while we change speakers?
Okay, do I need the microphone or can you hear me? You can hear me? Great. So, thank you very much to Norman for inviting me to speak here. And what Norman asked me to do is to talk about function, but with a special emphasis on tissue doctor imaging and, and strain imaging. So that's what I'm going to do. And if you don't understand anything in one talk, don't worry about it. We're getting back to the same things in many of the talks, and I'll revisit the concepts that I'm going to speak about over and over again. I'm going to take a bit longer in this talk and explain the basics of what's going to come when we speak about specific lesions. So what I'm going to talk about are really what tissue Doppler strain and strain rate imaging are, how we acquire them, and what their applications for are congenital heart disease, which we'll talk about in the specific lesions. Now, you know, Norman said to me, I want you to talk about the new techniques, and everyone calls them the new techniques to evaluate function. Certainly those that are in pediatric cardiology use that terminology. But I just want to stress that they're not so new. Tissue Doppler has been around for over 20 years. Even strain imaging by Speckle Tracking has been around at least 6 years or so. And I say that because they still have not become routine when we use them in pediatric cardiology. And we have to think of those reasons why. There are many, many problems with these techniques, and if we have time at some time during the course, I can give a whole lecture on what the problems are with these techniques. We don't have that much time now. But what they have allowed us for the first time in a bedside manner is to evaluate regional function. We look at the heart and we measure ejection fraction, we measure all kinds of indices. They are global indices, and for the first time, except for MO, which is along one scan line, we are able to measure different regions of the heart and say what different regions are doing. So we're not talking just about the global economy, we're asking what's happening in Italy, what's happening in France, what's happening in Canada and the US, and we're able to differentiate the two. That's a big difference in how you look at the world and how you look at function. So let's just define what function is. And there are many definitions of function. It's actually a bit difficult to define. But if you look at overall cardiovascular function, it's the ability of the heart to supply blood and oxygen to the tissue according to their needs. If you look at the heart as a pump, which is how we've classically looked at the heart for decades and hundreds of years even, then if you look at the heart, it's the ability to generate enough pressures to eject blood and to supply blood to the tissues, but it's also the ability of the heart to fill adequately under low pressures, which would be diastolic function. And then if you look at myocardial function at that level, it's just the shortening and lengthening of the tissue. Now this is a slide I borrowed from Bart Beingen's review on the subject. And when we're looking at function, we can talk about intrinsic function of the myofibers, the myocytes, if you will. We can talk about regional function of the heart muscle, or we can talk, as I told you, about the global function, which is the pump. And at every level that we're talking about, we should talk about two things. The ability of the heart, or the myocyte, or the myocardium, whatever level you're looking at, to generate force, and then the change in dimension that happens with that force. So the myocyte is going to generate force by its inherent ability to do that, but it's going to change its size as it does that. The heart is going to generate pressure to open up the aortic valve, and then it's going to change its dimension as it ejects blood. The muscle, if you're looking at just one region, it's going to do the same thing. So we're talking about a stress, dimension, or strain relationship. And so up to now, we've only really talked in terms of pediatric cardiology, mainly about the pump function, the deformation, the ejection. And now I'm mainly going to talk about the muscle deformation, that strain and strain rate imaging. But we do that because we think it reflects the intrinsic myocyte level. We don't know how to evaluate the myocyte directly yet. We may get to that, and certainly with MRI, not in the beating heart, but you can try to do that ex vivo. But the best we have is to try and assess what the change in the muscle to reflect the change in the myocyte. So really, we're looking at the myocyte that are then aggregated into aggregates of myocyte that form a structure. Those fibers are oriented in a certain way, and that brings about to bring a very complex, and I knew it wouldn't work as I hit it. Sorry, I'll bring that back in the next lecture. The heart moves in a very complex manner. I know why that's not working. I'll fix that for the next session. So we're really looking at the geometry of the heart. We're looking at the loading conditions, the preload and the afterload. So if you want to look at that simply, and I'm simplifying things here a lot, but the amount of blood that's coming into the heart that's stretching the fibers to their certain pre-contractile length, and then the afterload, which is really the force that the heart has to overcome to eject blood. And that force is the pressure in its own walls at the end of systole, the blood pressure, for instance, and many things that make that up. So we have to look at the effects of loading, but we also have to look at the electrical activation and the regional loading, and then heart rate itself and the force-frequency relationship, which I'll explain in a few minutes. So current applications of this technology are pulse tissue Doppler, color tissue Doppler, and strain rate imaging. I'm just going to put in a USB because I think that it's looking for movies linked to the USB. So I want to have my movies play. I'm going to skip over the physics themselves because we don't have time, but just to say that pulse tissue and color tissue are not acquired in the same way, and the velocities you get from them are not the same. But let's start from pulse tissue Doppler. So you've already heard from regular Doppler from Dr. Silverman what regular Doppler is. So for many years, there were these artifacts that people threw out from the tissue itself, and those tissue were low velocity, high frequency signals that were thrown out in order to increase the quality of the blood Doppler. And until people realized that you could then Doppler the tissue directly by exactly filtering for those same signals, which again are high frequency but low velocity, and those are the tissue Dopplers. And when you place a pulse tissue Doppler anywhere in the myocardium, and here it's just shown on the mitral annulus, you typically will get this very early during the isovolemic contraction. You'll get a peak. You'll get then the main systolic peak, which corresponds to ejection, if you will. And then in diastole, you'll get early diastolic filling, or early diastolic motion, and late diastolic motion, which corresponds with mirrors the regular Doppler E and A wave that you get through the mitral valve. And here I've shown you an example from a paper of the systolic, early diastolic and late diastolic wave, and here's just another example, same thing, isovolemic contraction, systole, early diastole and late diastole, E and A prime. And there are normal values in the pediatric literature. There are many papers today. I've just brought one of the few ones from, one of the earlier ones from Ben Idem, and you can see that over age generally velocities increase. We'll get to that. But you'll also see, if you look at the E, which is the mitral inflow, over the E prime, which is that early diastolic wave, which is thought to reflect filling pressures, you'll also see that it decreases with age. It decreases with age because the E prime increases with age as the E wave, that early filling, stays constant. But filling pressures, if you have to measure them in the heart, don't increase or decrease over childhood. They remain relatively constant until we get much older, more or less to Norman's age and Steve's age or older. But anyway, so be careful of what you reflect. You have to remember that we work in pediatrics and things change at different ages, and that's why papers like this are important. Let me just, I want this to work, so forgive me, let me open up from my USB key, and things will work much better. Sorry about that. I think this is what's going to link the movies. Okay, so that was pulse tissue Doppler. Color tissue Doppler is we're just doing color like you do on the blood flow, but remember, in this way we can, instead of just interrogating one point in the heart, we can now interrogate many regions at the same time. I can increase or decrease my area of interest to wherever I want. But remember that these are mean velocities, not peak velocities, so the values are going to be about 20% lower, but you can still get the same signals. You'll get a systolic velocity, you'll get an early and late diastolic velocities. Here's aortic valve opening and closure. And in this way, I can actually place regions of interest at multiple positions within the myocardium and look simultaneously in different regions what's happening, and that's important for timing of events. I can integrate the velocities to get displacement, which is just a motion, okay? If I'm walking here, I've displaced about a meter. So you can measure the displacement of the mitral valve, of the tricuspid valve, and that's also a functional measure because how much the heart is moved and translated tells me about how much it's functioning. This is with a click of the button. It's very easy. Here he showed it on the 3D. It's one click of the button, you can get displacement. And I'll come back to the slides. They're phenomena that you cannot see with the naked eye very easily, like motion that's happening here after closure of the aortic valve, which tells us about dysfunction in the heart and ischemia. I just want to go back to this principle of isovolemic acceleration because I'm going to come back to it in many lectures. This was published by Andrew Reddington and Michael Vogel. This is this initial systolic velocity that happens simultaneously with the QRS complex here, and it happens during the time when both the aortic or the mitral valve is closed, the aortic valve is not yet opened, that phase of isovolemic contraction, and this early tissue velocity is relatively independent of loading conditions because both valves are closed and the volume in the heart is constant, so any motion during that short period is not influenced by volumes or by loading, and so they've shown how it is not influenced here if you blow up a balloon in the IVC and decrease the volume load, or you increase it if you blow up a balloon in the pulmonary artery, the IVA stays relatively constant, IVA, isovolemic acceleration. And they showed how it corresponds with other invasive measures of contractility, which is the inherent ability of the muscle to contract, such as DPDT and end-systolic elastins and others. And then from IVA, you can do something, for instance, called the force frequency response, which really describes the increase in contractility of the heart with an increase in heart rate. So if you went out running now, your heart will squeeze harder, not only faster. So as it beats faster, it squeezes harder. So that's the force frequency relationship. So you can use IVA if you pace or if you exercise someone to measure this response, and that's a measure of function. It's also, tissue Doppler has also been important in assessment of diastolic function, certainly in adult cardiology, where tissue Dopplers are at the center, and I'm not going to go through the whole diagram, but at the center of how you grade diastolic function and how you estimate filling pressures in the heart. And that's because when your filling pressures increase, after an initial decrease in early relaxation, you then get an increase in those velocities, something called pseudo-normalization, because the pressures have increased and it's driving blood through the mitral valve, but your tissue velocities stay low. So you can use tissue velocities to show about the real diastolic dysfunction and the filling pressures. But tissue velocities have many disadvantages. One of them is this. This is a heart with dilated cardiomyopathy. You can see it's obviously dysfunctional. This child actually had myocarditis. You can see it's obviously dysfunctional, but if you measure velocities, they're almost normal. And they're almost normal because the heart is moving a lot. It's not contracting a lot, but it's moving a lot. And all you're measuring with velocities are motion. And so you get normal velocities in a dysfunctional heart. In everything we do in the world, in life, there are pitfalls. This is one of them. And for that, strain and strain rate have come about. And what strain is just a change in dimension from an original dimension. And I use this example of a train moving, and if you just measured the velocity of this train, you would measure it at whatever it is, 100 kilometers an hour. But the train itself has no strain because the carriages, all of them, are moving at the same velocity along the tracks. And the train itself hasn't changed length. But if the train, the first carriage had to stop suddenly and brake, the carriages would crumple into each other, and suddenly that train would have strain because its dimension would change. And strain rate is the speed at which that would change. So if you take an elastic band and you stretch it, that's strain. And if you stretch it quickly, that's strain rate, which has happened fast. I can demonstrate that in these clips from Pete Klaus. Here are two myocardial segments shortening that strain. They're just shortened from an original dimension. If we then look at this one, here's two myocardial segments. They both shorten to the same length, so they have the same strain, but the bottom one does it faster. So the bottom one has a faster strain rate. And if you go back, here's a myocardial segment that's shortening, and it's just pulling the green segment. That green segment isn't shortening at all. So if you measured velocities in the two, they would be exactly equal. But if you measured strain, here you'd have good strain, and then you'd have very poor strain in the green segment. And then you can have the opposite thing happening, where the yellow segment is actually pulling the blue segment and stretching it, so you can get the opposite strain, which is stretched in this case. And if you look at isolated myocytes from classic experiments and you look at strain curves, you'll see that they're similar. So we think that the strain in the muscle as a whole is reflecting what is happening on the myocyte level. And you can derive strain either from tissue velocities by differential velocities. I know I'm out of time, so I'm going to just move quickly. Or you could do it from speckle tracking. And I want to explain what speckle tracking is. It's tracking those individual speckles that you get from the muscle, from the refraction of ultrasound, or it's really the interference of the ultrasound. And so you can track these over time in vector velocity imaging or in other ways to get the strain. And this is demonstrated from this Mayo Clinic clip that was given, I think, to Norman by Ben Iden and then to me by Norman, and it's gone around the world many times. But it demonstrates the principles of strain imaging. So you can track the motion of the heart in the longitudinal direction, like this. You can track it in the transverse or radial direction. So what we usually look at in other indices like ejection fraction. And you can also track it in the circumferential direction, so in the circle in this way as well. So you can see these different vectors of motion, and we can track those speckles over time to give us the change in deformation. So to give us how much the heart is shortening or lengthening or thicken and thinning. And you can do this in different ways. And as I said, here's longitudinal strain, which we get these curves of the shortening and lengthening of the myocardium. Here's radial strain, where you get the thickening and thinning of the myocardium, and circumferential strain, which is again shortening and lengthening in that circumferential, in that direction. Now these things are more complex, because if you look at the base of the heart, it rotates in one direction, and if you look in the apex of the heart, it rotates in the opposite direction. That's shown in these two clips over here, and the net in these two lines over here. And the net difference between the two is the torsion, which is the ringing motion of the heart, which also contributes to ejection. By the way, this is the clip that didn't claim that first slide, so I promised I'd show it. So these techniques are probably useful in congenital heart disease, and this is my last slide, Chairman, so I'm almost done. Because they're independent of geometry, because you may assess right ventricular function more easily, because we struggle with that the whole time, and therefore we can also assess perhaps single ventricle physiology more easily. We have lectures on that. You can now quantitate regional function instead of just eyeballing it and say what you think. We can acquire this bedside very easily, although the post-processing still takes time. But we can do serial examinations, which I think we haven't done enough of yet. And even though these indices are dependent on loading conditions, they're probably less dependent on loading, and I'll talk about that in the next few lectures, than ejection fraction and fractional shortening. I'm going to skip that and just say that we have many serious problems with these techniques, and sometime, if there's time, I can expand on these much further. One of our main problems is in the reliability and reproducibility of the techniques, which is very important, and I think also how we interpret them in light of the loading, and I'll get to that in the next few talks. So I'm going to stop over there.
I have to personally apologize to all of you for not for any of the outstanding information you get, but it's gone over a little bit of time, and we'll take care of that in the next few lectures to get us back on track. Now, Dr. Hasbani is going to finish up this section of bringing us into the realm of cardiac MRI and its particular values and precision.
Okay, well, before I start, I wanted to ask how many of you guys see MRI regularly in your practice versus how many of you see it occasionally versus almost not at all. So how many of you guys see it regularly in your practice? Okay, how many occasionally see it? How many see it not at all? Okay, so I think that's kind of important because that's going to change what I explain and the information I try and convey. And rather than going into the physics of MRI, which is quite complex, I'm going to really show you guys the different image modalities this morning, what information you can get from the image modalities, and then we'll try and expand on that. So we'll see where that takes us. So why cardiac MRI in congenital heart disease? And the biggest reason is really improved anatomy. We know that in the neonate, the echocardiogram is fantastic in penetrating through the chest wall and letting you see a lot of the intracardiac anatomy and a good amount of the extracardiac anatomy, the vessels, the pulmonary veins, the aorta. As a child gets older, the anatomy gets harder and harder to see. That's especially true of the right ventricle, which is a key component of what we look at in pediatric cardiology. Many of the disease processes that we have are going to affect the right ventricle, and the right ventricle frequently is the ventricle that we're trying to see how it's functioning. Occasionally it's the only ventricle, and we're going to see how that happens. The other thing about it is cardiac MRI is great for volumes. Echocardiogram, we know, is not that great for volumes. It's difficult to acquire good volumes. Just like Dr. Friedberg just mentioned, the inter-observer and intra-observer variability with echocardiogram and volumes is big. And the difficulty with that with pediatrics is when you're going to try and do a study and watch several patients or a group of patients and how they change, you're not going to be able to get good information with a small power, meaning a small number of children that you're going to be able to watch. The other thing that's impressive with cardiac MRI is it beginning to give us information that we almost always relied only on catheterization to give us. Things like QP-QS, the amount of blood flow going to the lungs, the amount of blood flow going to the systemic flow. We could also get a QP more specific to the right lung, to the left lung, to the pulmonary veins, and so forth. And you'll see that as we go through it. The last thing that's really unique to cardiac MRI, and we're not able to get that almost in anything, except for maybe a little bit in the strain rate, is myocardial fibrosis. That's injury that happens to, thank you very much. Injury that happens specifically to the myocytes finding the location that this injury occurs, and then finding out why it occurs. So is it myocardial ischemia that caused this injury? Is it myocarditis that's causing the injury? And I'll show those images. And so there are many different sequences in MRI. I'm just showing you a good 10 of them that are technical modalities that we can get. So you're going to have to tell the technician or your radiologist what you want to get from the MRI. Rather than talking about all of these, which would be way overwhelming, I thought about talking about just the 5 that we frequently use in cardiac MRI, in congenital cardiac MRI. And then as other techniques that I'm going to show, I'll explain the technique as they become available. So Cine, the top one in the right corner, or left corner for you guys, Cine MRI is very similar to 2D echo. This is where we're seeing the function of the heart, we're seeing the anatomy of the heart. Then the one up at the top, sorry, I'll use. So up here you can see velocity encoded. This is similar to what Doppler is. We're going to see it in black and white in MRI versus the red and blue. This is first pass perfusion. You're watching the gadolinium or the contrast agent actually entering into the ventricle and watching the abnormality. As you can see here, there's an aneurysm. MRA, so angiogram, you can actually see this is a coarctation of the aorta with the collaterals. And this myocardial fibrosis that I was telling you about, this is what's called late gadolinium enhancement, or some people call it myocardial enhancement. And what you can see is the abnormality, and I'll explain that as well. So this is the list of them. The first one I'm going to talk about is the Cine. It's also known as by other names. And the reason this is a staple is it's going to give you the anatomy, it's going to give you the function. It's usually done over a breath hold, so the patient is going to hold their breath for 10 to 14 seconds. We could also do it as real time, and I'll show that. And that's improved significantly over the years. So about 10 years ago, we had this kind of image. And you can see it's pretty good, but not very crisp. Where now we do something called a SSFP, a steady state free precession. And you can see the image quality has improved significantly. The blood versus the myocardium border is much improved. And how does that compare to 2D echo? Here's your 2D echo image, and here's your 4-chamber echo or MRI image. Do the same thing in 3-chamber, short axis, and then right here in the short axis you're beginning to see this is your right ventricle, and this is your echo right ventricle. You can see the borders. You can see the pericardium, you can see the effusion or lack of effusion, and you can see the papillary muscles and how they're contracting. You also get to see the anatomy much better. This is a patient that had normal anatomy, but dextrocardia. Here's the chest wall. You can see the heart's been rotated. Here's the left ventricle. Here's the right ventricle. The left ventricle is anterior. And you can see all the structures and how they're relating to each other. Now we take the short axis stack, the same short axis that I showed you before. We start at the top near the aortic valve, and we go all the way to the base of the heart. And with that, we're going to see the function throughout. And using that function, we're going to then trace at the endocardium and epicardium of the left ventricle, and just the endocardium of the right ventricle at each slice, at end diastole and end systole. And we're going to get a huge number of numbers. But the thing that's most impressive is we have one number, the myocardial mass, at end diastole and end systole. And that allows us to check if the endocardium and epicardium that we've drawn in end systole and end diastole is equal. We know myocardial mass should not change over the cardiac function. So within MRI, you have your own variability that you can check on yourself to see that you've actually drawn the trace as well. You could also do a 4-chamber stack, so you can see the right atrium and right ventricle in this direction. This is a patient that has quite a bit of tricuspid regurgitation. You can begin to appreciate that and the dilation in the right atrium. Why is all this important? All of this is really at the end important because you want to see if your information is reliable and reproducible, right? Even if it's a little off, as long as it's reliable and reproducible, you're going to be able to use that information for studies, and you're going to be able to use that information to follow a patient over time. And so your inter-observer, one observer versus another, variability is very low. You're going to see quite a bit of the same numbers, whether you're doing the information or one of your colleagues. Your systolic mass and diastolic mass, which should stay constant, is also very low. And your ejection fraction by MRI compared to radionucleotide ejection fraction, which was used to be called the gold standard, is also very low, especially when you're looking at the ejection fraction at the lower rate. There's a little more scatter at the higher rate, but you're not really worried when the ejection fraction is 65 and higher on a patient. You know that patient is normal. It's really when the patient is on the lower end that you're worried about it. And how does that translate to cardiac MRI being used in congenital heart disease? The reason that that's important is the p-value that we have to use, the n value that we have to use to get good p-value is going to be lower when you're looking at ejection fraction and myocardial mass. You're going to have a very tight information, and so you're not going to have as large of a study number and as many patients in order to study them. And that's what's shown, especially true. Here's MRI. You have 260 patients if you want to look at end diastolic dimension. So this is very good with echo, and so the numbers are not that different. Now when you're looking at volumes, myocardial mass, and ejection fraction, your number decreases significantly. 2,400 or 900 patients when you're looking at echo, only 35 patients when you're looking at MRI. 600 patients for echo for ejection fraction, and only 91 for MRI. So that helps us a lot with patients and the patients' numbers that we can have in congenital heart disease. Now what is the cine images? If you have a patient that's young, can't hold their breath, or you're going to put them under anesthesia but don't want to intubate them, you could do the same images in real time. And I just want to show you they're not as crisp as the ones before, but you could still get a good number of anatomy. You can see the 3-chamber here. You can see the semi-4-chamber left ventricular outflow tract, and you can see the patient is breathing on their own throughout the imaging. Same thing here. This is a real-time patient. You can see the bicuspid aortic valve and the abnormal opening of the valve. You can again see that the patient is breathing on their own while that's happening. One last example of that. You can see a truncus valve. You can see the truncal valve is got regurgitation and is abnormal. You can see the right ventricular outflow tract, and again you can see the truncal valve abnormality. So let's move on to velocity encoded images or phase contrast. This is very similar to Doppler. What you're going to look for is you're going to look for the velocity that's happening in the heart. Unlike Doppler, we look at it either coming to you and out of you, or you look at it in the plane. So there's 2 different planes that you can use it in, and that's very important. This is going to be dynamic information that you're going to get. Now, the thing to look for when you're getting these images is you want to have 2 images being shown to you. One's going to be showing you the anatomy, and that's going to not be quite as crisp as the SSFP that I showed you, but similar to the first image that I showed you. And then the second one is going to show you the velocity. And so I'll show you an example of that. Here's the anatomy. You see the right ventricular outflow tract here. And then you're going to look for that same location here on the other side in the velocity. Now what happens, I'm going to take a second to explain this. Anywhere where there's air, you're going to get that old TV look. You know, that speckled look of the TV. Anywhere there's tissue that's not moving, you're going to get just a gray zone. Then when you get a velocity, or blood moving, you're going to get a black and white. And here you see the right ventricular outflow tract, and here you see the descending aorta. And you see there's a forward flow in the right ventricular outflow tract, and then there's the reverse flow of the regurgitation. Now, unlike Doppler in echo, where you get a Nyquist limit, and if you go too high beyond that Nyquist, you begin to alias, you really don't get that in MRI. The maximum velocity, per se, that we can get to is 30 meters per second, way higher than you're ever going to get in the human body. But if I set it up at 30, everything's going to look great. The same way that when you're looking at the pulmonary veins at too high of a Nyquist limit, you're not going to see the flow in them. And so you have to set a velocity that you think you're going to be at. Maybe it's 2 meters per second. And you get that, and if it's too low of a velocity, you're going to get a speckling effect, the same sort of speckling in the region that you're looking at. And then you know to go back and increase the velocity. And I'll show you examples of that. So this is the through plane velocity, and this is now the in plane velocity. And now we're looking at the pulmonary valve here, and I've shown you how we trace it. And when we trace the pulmonary valve like that, we're going to see a velocity, the velocity moving forward, the velocity moving back, and we're going to see also the volume moving forward, volume moving back. And so you get the systolic forward flow, the diastolic reverse flow, and this way you're going to get your regurgitation fraction. Just to show you a couple of other examples, here's a patient that had coarctation of the aorta. You can see the velocity happening in the coarctation. They had a jump graft. You can see that there is probably dilation at the anastomosis there, and the abnormality that's happening from that. Here's that same patient that we talked about earlier, the bicuspid aortic valve. You can see the abnormality that's happening there. And here's the speckled look that I was telling you about, where the velocity that was given to the machine to run the MRI sequence was too low, and so you're getting a speckled look in the center. Here's a patient that has an abnormality of the aortic valve with dilation. You can see right in the center the ejection, the regurgitation happening, and here's the regurgitation by 3-chamber. So moving on to late gadolinium or myocardial delayed enhancement. This is the information that I was telling you that is really unique to cardiac MRI. This is where you're going to see myocardial fibrosis, which is actual injury that happened to the myocytes. This is usually injury that is permanent. It was initially really found by ischemic coronary artery disease, but now we're finding that myocardial fibrosis happens in many disease processes. Myocarditis, we know that patients who undergo surgery can have this, transposition of the great arteries if their coronaries are abnormal, Kawasaki disease, and we'll see this throughout. I really want to explain this because it's going to be important. The tissue is characterized through this. Gadolinium is injected into the patient, and approximately 5 minutes after they're injected, you run a scout to see where the myocardium becomes black. And when you see where the myocardium becomes black, or what we call nulled, that's really the tissue point that you're going to start running it. And I'll show you guys exactly what I mean by that. This is EKG gated as well. So here's a patient where their myocardium is nice and healthy. You're going to look for this black donut. You'll hear me talking about that frequently. A black donut, all of it is black. This is the nulled myocardium. It's healthy, it's doing well, there's no issues with it. This is a static image. And here are different abnormalities that can happen. Up here at the top is myocardial fibrosis caused by ischemia. Here is normal myocardium, again, that black donut that I'm telling you. And here's where you're looking at the black donut, and there's insufficiency here. You see this enhancement. You see a black enhancement on the outside, white enhancement on the inside, and the black on the outside. This is just endocardial fibrosis, so just a small MI, versus a transmural myocardial infarction, where you see there's no black left behind it all. And then there's different places that the myocardial enhancement is going to occur, depending on what caused the injury. So for example, in myocarditis, we see a delayed enhancement that happens right in the center. And how do we know that this is really fibrosis? There have been many studies that have looked at it. One of the big ones that's quoted frequently is by Raymond Kim in Circulation, where he looked, here is the actual tissue, and here is the MRI. And you can see even at very detailed, here's the fibrosis, and here's the cardiac MRI image. And you can see how detailed it is and how much similar it is to the fibrosis. Now this is in myocardial infarction. The same thing has been done now in myocarditis. Here is the normal tissue we talked about, nice myocardium, black donut. Here is normal myocardium again, and here the histology and very specific microhistology, all normal tissue. Now you're looking at the delayed enhancement here. You see the black donut on the inside, white in the center, and then black around it. And the same thing here at histopathology, right in the center, this mid-myocardial enhancement which is consistent with myocarditis, both in the mid and in the base. Here's a patient I'm showing you their ejection fraction. You can see that it's actually not bad. The heart is working pretty well, but then you see a very nice enhancement all around. You see that mid-myocardium, very specific for myocardial disease, myocarditis. The same patient in the 4-chamber, again, you can see that, and then you can see the abnormality all around. Why is this important? Well, you know, every so often patients present very similar to myocarditis, as this patient did, and we took him to the MRI machine. You can see the black myocardium, nice and healthy, but what you can actually see is there's pericarditis. You can see both the visceral and parietal pericardium are brightening, and then in the center you can see the small effusion that's there as well. This is also important with patients with hypertrophic cardiomyopathy. You can see the thickness that's occurring here. You can see the ejection fraction is good, but quite a thick left ventricle, and then you can see the abnormality that's happening here in the lateral wall. And this is going to become very important as we're recognizing from the adult studies now into the pediatrics that the amount of enhancement that you have present is going to help you risk stratify your patients as to how complex these patients are, the increased chance of sudden death, and their increased chance for ventricular tachycardia. And so this is going to be very important as we begin to risk stratify patients with Fontan anatomy, for example, or risk stratify patients with hypertrophic cardiomyopathy, or any of these patients. If they have a lot of this gadolinium enhancement, they have a lot of fibrosis in their heart, they are going to be at higher risk for sudden death. They're going to be your patients that you're going to want to put a defibrillator in. They're going to be the patients that you're going to watch more carefully. And these are the patients that potentially are going to need to have intervention and ablation and other abnormalities done to them. The next one I want to show you guys is gadolinium enhanced MRA or angiography, and the twist, which is also angiography. And the reason these are important is because in MRI, what you want to obtain is information that first we can't get in other modalities, but second, possibly get information that you could get in other modalities, but they were more invasive. And really up to now, looking at the vasculature outside the heart really was left to the interventionalist. You had to go in, you had to give contrast, and you had to do it invasively. And MRA is becoming one of the ways that we can look at this information with a non-invasive technique that does not involve radiation and get very beautiful images. So here's an image which, the story I say is the first time I brought this image home and I was working on it, my husband looked over my shoulder and saw this image, and he's not a physician. He's quite proud that he's not a physician, but he's heard the stories that I've told him when I've come home in the middle of the night, and he looked at this image and he said, that's coarctation of the aorta. And the reason that that's important is someone who's not even in the medical field can look at this image and get the information out of it. And if someone that's not in medicine can get it, imagine what we can get when we are in medicine from it. Versus echocardiogram, where you have to have someone point it out to you if that's not your modality that you use regularly. You can see not just the coarctation, you can see all the other vessels, how they're dilated. You could see the tortuosity that you hear about all the time. And in this patient, you can see that there's only one kidney. Here's another patient, also gadolinium enhanced. She also has near interrupted aortic arch. And now you're going to say, this image isn't as beautiful as the one you showed before. Now the reason for that is this patient also has a VSD. And so the enhancement that goes through the left ventricle is returning to the right ventricle, and therefore you're going to get contrast that continues to enter into the right side as you're looking at the left side. And you can see her septum. I'll show it when it comes around again. You can see the septum here, and you can see the two ventricles, and that's why you're continuing to see contrast in the right side as well as the left side. Here's another patient. You can see a dilated aortic root all the way up to the transverse arch and then the descending arch, so it looks normal. And so that's gadolinium enhancement just in the location that you want. Now frequently in congenital heart disease, you have disease both on the left side and the right side. And you want to see the contrast as it's going through both sides, the right ventricle and then the left ventricle. And twist really allows you to do that. What this is going to do is it's going to follow the contrast as it's entering every single chamber from when you give the contrast usually in an upper extremity and go through it. And so you're going to get images like this as you see the contrast at each one of them. And now you can play the image. And you can see how the contrast is entering in every location. And then you can stop it in the location that you specifically are interested in and make that into your 3D rendition. And you can see if it works. This patient that has a Hancock valve right at the RV to pulmonary artery, and you can see that there's some stenosis in that conduit. And you can see the pulmonary arteries very nicely, the right ventricle, and look at that image. Here's another example of that, another patient, a dilated right aortic arch. You can see the contrast as it's entering, you can see the pulmonary arteries, and then you can look just at the aortic arch. In that specific patient, you thought, well, tetralogy for low, I really need to look at the right ventricle. And then you do this twist and you see that I probably should pay a little attention to her dilated overriding aorta that's continuing to get larger. The last thing I'm going to talk about today, or this morning, is the first pass perfusion. Now, first pass perfusion, if I was an adult cardiologist, would be the first thing I would talk about. First pass perfusion was why MRI was really invented. You're going to give gadolinium and you're going to watch it as it enters the myocardium specifically and watch if you have a defect if you're an adult cardiologist. Now in pediatrics, usually the coronary arteries are normal and you're not looking at what happens as the contrast enters the myocardium, but what happens around it. And so in gadolinium in the first pass, here's a patient that has an atrial septal defect, and you're watching as the gadolinium enters the left ventricle, and then you see it coming right back to the right side again. Here's the first pass of a patient. You can see, I showed this on the first image, you can see the left ventricular aneurysm in that region. And here, just so you guys get an idea, is a first pass perfusion for myocardial perfusion. And what you're going to see at the end, you're going to watch the myocardium get bright, but here it stays black. And the reason it stays black, and I'll play this again, the reason it stays black is because there's been this coronary artery defect and coronary artery obstruction. And so the myocardium all gets perfused except for the region where the coronary artery is not able to perfuse it. And this is really a staple of adult cardiac MRI. This is what they look for and what they study very carefully to see if a patient is going to improve when they did revascularization. And more in the United States, patients are going under MRI and looking at this, as well as looking at whether they have fibrosis before they actually get their CABG or their bypass surgeries. And if it's not present and that you can't have hibernating tissue, they're not going to improve after their CABG. Now, just for future ideas, fetal MRI is definitely here. Fetal cardiac MRI is not here yet, but it probably will be. You can see very nice image of the fetus, the brain, the eye, and waving to you, hoping that you will take a look a little closer to them. And these are my girls, just as hopefully when they get older, these will be the images, modalities that they can use. Any questions?
Yeah, I'm afraid if there are some pressing questions, I think we should have them now from the audience. We're going to have to forego the symposium on this section so that we can try and keep up with time. So if you have questions, this is the time to ask them.
You talked about the sector angle. So what would be the optimum angle we should use for 2D echo?
Which angle, I'm sorry?
Sector angle.
Oh, the sector angle. Well, that really depends on the type of equipment you're using and how fast the scans are on that equipment. The standard 90 degree is, or 60 to 90 degree, somewhere like that. If you want to get higher resolution, you can cut down the sector angle. In pediatrics, it's generally not necessary because the problem is a problem of sector angle plus depth. And so the time is related to both of those. So if you're cutting at a very much shorter depth, then the signal doesn't have to be sent and received over those entire frames. So you can get much better sector angles. But any time you want to get high resolution, you either decrease the sector angle or the sector area that you're looking at. Okay? All right, sector angle. Anybody else?
Can I answer that as well from my perspective? Because it's an important issue. Who answered the question?
Yeah.
So in tissue doctor imaging, it's critical, a critical issue is frame rate. Because the faster you image the heart, the more information you're going to capture. If your frame rates are too low, you're not going to capture peak events and you're going to underestimate function. So if you're looking at specific areas in tissue doctor, you want a narrow sector angle, which is going to increase your frame rate. If you're looking at things like synchrony, where you need to look at two walls, you're looking at the motion of the left ventricular wall versus the septum, you need to increase your sector angle. So it's going to influence frame rates and imaging. That's what's important.
I think what Mark talked about, I think, is equally important for 2D, for function analysis, and for 3D. Frame rates are really important. Because when you have high frame rates, you're able to capture myocardial motion in a way that makes sense with the fast heart rate of the baby. So the slower the patient's heart rate, the lesser the frame rate that you can get away with. So the other side of this is that most echo recording, digital recording systems, the echo pack systems, if you will, whether you're talking about single or it doesn't matter which system you have, unless you set it up that way, the vast majority of them will only store a maximum of 30 frames per second. The TE system will probably store more if you ask it to, but if you do, then it will store a huge amount for you, and if it stores a lot, then your computer department will get very angry because your server will get overloaded. So those are the balances. So in general terms,
I can just start and show the anatomy.
30 frames is broadcast TV, and it will be very clear to you, especially when you add on modality like color, put color on that, even with 2D, put color on that, and frame rate is going to go down and see a number, and then, in general terms, if your frame rate is 1/6 of your heart rate or lower, you probably need to do something that narrow your sector.